All right, good morning. First of all, thank you all for joining. And I would like to take you through this interesting problem. And at the outset, I want to thank Selvi, Sylvia, Ravi, Sriram, Roy, and Joseph for joining us. And I want to thank my mentor, John Stoline, Mr. Charles Butt, and Ms. Angela Deal, and also my institution for their support to do this program. And so one thing is I'll put this one up there, how to get CME for learning from this event. And you have a link here, the HTTPS, YouTube, whatever. But if you can't register that, you can go to my YouTube channel, and I set up a small video that shows step by step, and you can search an MDACC endoscopy refresher CME. If you put that video will come, and it will help you go through the process and set up your CME account, and you should be able to get CME every time you join us. So something is good for all of us, and I'm really grateful that the institution allows us to do this. So this is a story. This is a 40-year-old man, actually spouse of one of my colleagues. He was in good health, and but he has a family history of colorectal cancer. His maternal grandpa at 60 years and uncles in their 30s developed colorectal cancers, and no other cancers. So with that, why don't we ask Selvi and Sylvia discuss how do they approach this patient?
Shall I start?
Sure. Go ahead.
Yes, so I think this patient has a family history of colorectal cancer, which qualifies him for further investigation. He has no first-degree relatives with cancer, but he has an uncle under the age of 50, and the maternal, I was wondering, the maternal grandfather in his 80s. And I was wondering
60s.
whether
60s, it looks like.
60s, sorry. I was wondering whether the uncle is also from the same lineage, maternal uncle.
Yes.
Okay. Because in this case, he would not fulfill the Amsterdam criteria, which says 3-to-1 rule, 3 family members with colorectal cancer over 2 generations, one of them under the age of 50. But he would qualify for further investigation according to revised Bethesda, because he has 1 family member under the age of 50. So I think that's relevant for the next step. But first we have to focus on the patient. So I'm listening the story.
Okay. Selvi, any other thoughts?
No, Raju, I agree. I'm glad you got the family history was obtained and you got that information. It's important to get which side of the family their colon cancer is on and what age they were diagnosed. So I'm glad that information is here for us. I think it's interesting that he is in his 40s, or the patient is in their 40s and is getting a colonoscopy. So they don't quite meet criteria for average risk screening because they're not age 45 or 50. He or she is getting screened, presumably. I don't know what prompted that. I think I'd be more interested to hear that.
I think it's, I said, this is a husband of one of our colleagues who works in the endoscopy suite. So when we see a lot of cancer, sometimes, we go through that, right? Maybe this is something we need to be proactive. And
just the family history.
Right. So You know, it's also interesting when I saw him in the clinic, I'm going to make a comment which is important that will tell us a little more down the road, is he was very quiet, you know, most of the talking was done by the spouse and saying, okay, this is what we have. I'm here to get him screened, you know, and he was very quiet. So we did the colonoscopy, and the colonoscopy showed nothing major, maybe one tubular adenoma in the colon on the right side, small one. And then when we come into the rectum, this is what we see. So Roy, any comments as this is going on?
It's a non-polypoid lesion, most likely a depressed lesion. It's about 2 centimeters in width. So the depressed appearance by itself is a worrisome feature because when it's large, then it has a very substantial risk of submucosal invasion. So we are looking at the appearance. We have classified it. It's probably Paris 2C, but in order to really appreciate the depression, you should really, especially cases like this, you should really spray indigo carmine and look at it. It's worrisome.
Okay. So this is what we did. So we did the NBI, and then we tried to do some water to get a little bit of a better view. Sometimes people have suggested that there's an article in Video GIE where they've nicely shown that when you want to see some details, you could actually get a little better view when you take away the air interface and see underwater. And then we did a near focus, as you can see. So any comments on that now?
I haven't seen the near focus. Did you do it? Oh, right now?
Yeah, it came and went away. So
Okay. I don't know. It's it has some patterns, but I haven't seen the entire thing. So
okay, all right. Let me go and show you.
in the border, it's a little bit of pulling. It's not as impressive pulling, but I think this is a depressed lesion. It would be a little bit. I think the NBI I couldn't really appreciate it, but I would be suspicious for this lesion to contain at least a submucosal invasion or high-grade dysplasia, and I would want to cut this end block.
All right. Any other thoughts, Sylvia?
Yes, I very much agree with Roy's comments. This is a lesion highly suspect of deep submucosal invasion, I would say. because of the presence of depression at general appearance, because the classification, it's a laterally spreading tumor with a at least pseudo-depressed area, which means at least 35% risk to contain submucosal invasion. And I couldn't see very clearly the pattern by enhanced endoscopy, but I think I couldn't see amorphous sign, but I think at 6 o'clock, there is an area of irregular pit pattern. So it could be a 5-eye irregular pit pattern corresponding, Roy, please correct me if I'm wrong, corresponding to a GNet 2B or NICE 3. So
I don't
all
know nicely. It's just not convincing yet.
okay. So altogether,
There's pattern there.
mhm. So altogether would pinpoint to a high risk lesion to contain submucosal invasion, and unblock resection would be the best strategy.
Right.
Yeah.
Sriram?
Yeah, looks like it is beyond my endoscopic capabilities. I agree with all the conversation so far, and my suspicion is there is tethering in the submucosa, and I may not be able to get it by one and block. If someone can do an ESD, maybe, but I have no proof, but gut feeling is that this is more than just what we are seeing.
It looks tethered. It
Yes.
looks attached.
Right, right, right.
Mm.
And to me,
And
the
it
thing
looks
is,
firm.
yeah, the thing is when you're taking care of a colleague's spouse, somebody who's young, and then you find this lesion, you can think about what's going on in your own mind as an endoscopist. What are you going to go out and tell, right? Somebody in their in their 30s or 40s. So
We needed probably, even though if it is me managing, and if we needed proof to be able to convince the person for surgery, I would do a large segment resection of that most suspicious area, knowing fully well that I may not be able to get the whole thing a satisfactory resection as a diagnostic method rather than attempting as a therapy.
So as this case was going on, I thought that, okay, this is a 2C lesion. That's what I thought, given the family history, right? Two relatives, grandpa and an uncle with colon cancer, in their 30s. So I thought, okay, let me inject and see. And as you all pointed out, this lesion is quite tethered. And usually when you inject like that on the proximal side, and if you think your injection site is the summit, you should have a nice filling and lift of the lesion as well, similar to what you see on the other side. But so what do you think about the lift, Roy?
Not bad. Inject some more. The
So
front part
then-
may not lift though, and there's more.
You can see that lift actually did not happen. Basically, you see the lift outside, but the lesion itself has become more depressed. And so the thing is, I thought that I don't do ESD. I don't have the skill set to do ESD. So whenever we see a lesion like this, we tend to call one of our colleagues, and I call one of my colleagues, Pat Lynch, to come and look at it. And we felt that, okay, this looks a little more tethered. Maybe we should take some biopsies, because this is not something that I could cut with a snare, because the snare will end up slipping quite a bit. And also at this time, we didn't have Philip G., one of my colleagues who has experience in doing ESDs. So he was not, he has not yet joined with us. So the next thing is we try to do biopsies, and I basically used a jumbo biopsy forceps, hoping that I get a little bit of a better tissue. Normally I use regular biopsy forceps, but for some reason I felt that this looks tethered. It may be very hard to biopsy with a regular forceps with a smaller cup. So we went ahead and did the biopsy, so the jumbo biopsy. As you can see here, I'm also putting in a little bit of water to see if there's an area that is fragile. And if it is, I would like to go there and take the biopsy, because that's going to be the area that will give us a diagnosis. And so we went ahead and with the biopsies, and that's what you're going to see. And I'm trying to figure out where would I biopsy. In my own mind, I felt that given the fact that this lesion is probably cancer, and it's low in the rectum, and maybe something that could be cut if we prove it to be cancer by somebody else who could do ESD. At least keep the options open. So I thought that it's better to biopsy from the edges of the lesion. So that's what we did, the biopsies. And so you can see one thing is that I felt was when the biopsies were being done, I felt that it was quite tough to take a biopsy. And it almost had that so-called leathery feel, right? It's very tough to pull the tissue, as you can see here, And for the sake of any trainees who are here today, when you want to document this lesion, you want to document the location. It is in the lower rectum. It was about 5 centimeters from the anal verge. And then you also want to document whether it is on the left wall, right wall, anterior wall, or posterior wall. And how do you do that? If the patient is in the left lateral position, that's how we position the patients for colonoscopy. You put water and see where the water is. Here the water is at the 6 o'clock, so that's your left side, and opposite wall will be right, and the right side, the east side, will be anterior. So this lesion is in the left lateral wall and extending into the anterior wall. So, so get into the habit of putting some water, figure out where your left wall is, and then in relation to that finding, you could describe the location of the lesion in terms of either anterior, posterior, right or left. So something to keep in mind. Okay. So what
Raju,
is it? Go ahead, Sylvia, go ahead, please.
Just a question. Would you place the two?
Probably I didn't put a tattoo here because I could describe exactly where it is, and this lesion is quite obvious. And I don't put a tattoo in the rectum. The only time I put a tattoo in the rectum is if I think that I looked at a lesion that is submucosal and I think it is a carcinoid, that I have to come back and resect, or maybe if you want to send that patient to somebody else for resection, then I put a tattoo in the rectum for submucosal lesions like carcinoids. I think it's a good practice to put a tattoo when you find a carcinoid that you don't resect immediately, or even if you resect for follow-up. For a lesion like this, I thought that it is, as you can see, the moment you are at the dentate line, you could actually see the lesion. So I didn't put a tattoo here.
And maybe a second short comment. Presence of such depressed lesion in this young patient in combination with a family history increases my suspicion of a Lynch syndrome. In our experience in Lynch syndrome, non-polypoid colorectal neoplasms, flat and depressed, are 3 times more often than polypoid lesions, and even 6 times more often in the proximal column. But anyway, Lynch syndrome patients have very often this kind of lesions. So this would increase my clinical suspicion of a hereditary form of cancer.
That's good. I really appreciate that comment. So actually, it's I finished the case and then I came out and I called my colleague and I said, I'm a little bit worried about this lesion. One possibility is that we are probably dealing with cancer. And the other possibility is whether it is solitary rectal ulcer syndrome, because it was tough, and that was the other possibility we should always keep in mind. So, and I told her that we will wait for the biopsy results. And it was a very emotional reaction, for a young lady with her husband having this type of problem. And so that's the other aspect, how to take care of the family members when you're dealing with cancer diagnosis. So for the sake of any fellows here, I want to share with you, you want to take a lot of pictures to document in your report. As you can see here, I've got rid of some of the pictures in the cecum to sigmoid colon. And this is the rectal lesion, white light, NBI. And these are the pictures that are trying to show that there's a depressed component and then going close by and then coming here to show that you're at the dentate line, how far in, so that if in case you are not going to follow up and somebody is going to take care of this patient later on, they have all the landmarks. And then with the chroma endoscopy with the dye spray, right? So, nowadays, you can take and store as much of a digital image as possible. We shouldn't be thinking twice to document. And then again, where I've started taking biopsies from the edge to document that. And then, in this one, the fact that it did not lift. So get into the habit of taking a lot of images. It will help you for your own learning to improve your quality of colonoscopy, but also from the quality of care, subsequent care of the patient. These things are very helpful. So something to keep in mind. So, and when you put a report, I've just put the report, I basically typed it. I didn't want to copy and paste. So this is a 40 millimeter scar was found in the distal rectum at 5 centimeters from the anal canal verge on the left lateral and anterior wall. Biopsies were taken with a cold biopsy forceps. Biopsies were tough to take. In brackets, I put in underlying fibrosis, differential diagnosis, solitary rectal ulcer, given his history of constipation versus early rectal cancer, did not lift for resection. And the biopsies were taken from the edges of the lesion. So it's good to put a detailed report so that you could go back and even if you review this case 10 years down the road, you know what exactly happened. So
Could
the
you feel
pathology
it?
came back. Go ahead.
Could you feel it? I mean, you put your finger in there and it's within finger reach.
I could not feel it, sir. I could not feel it, you know.
Raju,
Yeah.
was the constipation bad? I mean, was he really straining to go?
No,
Was
the
there
problem,
prolapse?
the thing is, I'll come to that constipation part of it. It's interesting when I saw him in the clinic with his wife. His wife did most of the talking, and he was quite, he was not, I had to ask him several questions to get any history, and he was underplaying his story in terms of the constipation. So when I saw him, my focus was on the family history, and I said, okay, you have family history with 2 members, and I was thinking maybe thinking about, okay, high risk for cancer. And when I found this lesion, I thought it was probably like Sylvia, Roy, and everybody commented, I thought it was probably rectal cancer. But you see a lot of cancers, they're not tough, right? They are very tough to, this one was very tough to biopsy. And when I was examining in close range, white light, narrowband, and chroma endoscopy, I could not see the granularity, or the disrupted pit pattern of type 5 or whatever here. But having said that, I thought that, okay, maybe this is a weird thing. And when I did the water jet, there was no spontaneous bleeding. So even then, for some reason, my family history stuck in my mind. I was thinking it was probably rectal cancer. But the pathology came back as, rectal mucosa with granulation tissue and fibrosis, no dysplasia or malignancy. So I basically reached out to the family and I told them that let us go back and rebiopsy. And I think maybe it is sounding like a solitary rectal ulcer syndrome, but I want to be absolutely sure. And the fact that I biopsied from the periphery, I thought that maybe I missed the diagnosis because I didn't take it from deep center, right? And I didn't do that with the hope that if it comes back as cancer, we still have an option for him to do ESD if it was, if it can be arranged. So that was my thought process. So when I saw this, I was a bit relieved, but not yet out of the woods. So we arranged for a repeat colonoscopy. And Pat Lynch, my colleague, actually, who saw the lesion with me initially, went back a week later and he biopsied extensively. And the biopsy showed, again, thickened biopsies of a thickened rectum area showed ulcer, mucosal fibrosis, and changes suggestive of mucosal prolapse, no tumor seen. So I would leave it here. And we have Dr. Graham and John, Dr. Stroline. I want to hear their comments.
Maybe a short comment. We have seen a similar case, and I have reported it in GI endoscopy a few years ago. And we had the opportunity at that time to examine it with the confocal laser and the microscopy. So in real time, we could see the crypt architecture and the vessel pattern. And in contrast to the macroscopic appearance, which was very suspect for a malignancy, exactly like in this case, the histologic pattern with by endomicroscopy was absolutely normal, beautiful crypt architecture, normal vessels. I will share the case after the session.
Okay, that's fantastic. Thank you so much. Roy, any comments? Dr. Graham, Dr. Stoline, Selvi, Sriram?
I think this is why it is important that we follow a very we follow the framework of looking at the appearance, and then we classify, and then we actually confirm the diagnosis with the enhanced endoscopy. So here we couldn't confirm one way or another. So I think you did the right thing, that it could be something not neoplastic.
Well, it seems that this shows a problem too of possibly having the wife in the room, and it's time to throw the wife out of the room and talk to the patient and to see what he thinks is going on, because he's going to tell you the right story.
Yeah. Thank you, Dr. Graham. I really appreciate that. I think it was COVID, right? In COVID, we would have figured out, because no patients, relative was accompanying the patient. So, yeah. Yeah, it's no, I wanted to present the case as it happened, because I don't want to sugarcoat, because in life, you learn when you're true to yourself. I think it's a very important point Dr. Graham made. Sriram, Joseph?
Yeah, I have a quick comment. It's very interesting. About 15 years ago, I've seen something like this. When I was practicing in India, a patient was referred to me as a rectal cancer, and the long story short, they were suggested resection. So they came for a second opinion, biopsied, and showed multiple biopsies. After visually it looked like cancer, but multiple biopsies showed suggestion of solitary rectal ulcer, and eventually it was treated with APC and responded well. But the point is that the confusion between the two. And most of these patients with solitary rectal ulcer, at least from that background, have on further history, they don't they don't complain, but eventually after second or third session of conversation, they would come with a story of finger evacuation. Because of the mucosal prolapse, they have this feeling of constant feeling of incomplete evacuation, and frequent trying to evacuate. Some of them use digital evacuation, and that constant digital evacuation combined with the mucosal prolapse and local ischemia aggravates this. And I suspect in this guy who is hesitating to give any history, probably there is a component of that. In fact, I have a video, maybe sometime I can share that, where the people who do this finger evacuation, I think the rectum sensitivity is such that a certain distension, when we do colonoscopy, when rectum is distended with gas, it stretches and gives the same feeling. And I have a documented record where the patient's finger keeps moving under anesthesia when the rectum is distended. And when I take away this suction, and then the finger movement comes down, because it's an automatic reflex that they develop over a period of time. I'll share it sometime next time.
Okay, thank you.
Dr. Raju, can I make a comment?
Yeah, please, Aman.
So, I think whenever we see something like this, we are very hesitant to take biopsies, especially if we have to refer this out to ESD or transcranial mucosal excision in the rectal lesion by a surgeon because of subsequent fibrosis. So, and many times, like the ESD, people who do ESD or large EMR, they also, tell other GI colleagues that try not to do biopsies. And I know you also took the biopsies at the edge initially. And so I think this brings up some of that dilemma, that where, sometimes they say don't biopsy at all. So somebody could have, or in some place, said, okay, I'm not going to biopsy this and refer it for ESD. And the next guy could have directly gone on to the EST. I'm not sure. I mean, I don't know what the large center approach is for something like this. Do we biopsy, and how much we trust those biopsies? And would they do EST only if the biopsy shows something?
Okay. Roy, you want to take this question?
No, it's okay. You take
right.
the question.
All right. So the
I
thing
can
is,
take that.
no, I'll put it this way. When I was doing the procedure, for some reason, in my mind, I thought it was cancer. But when I was looking for those signs, except for the depressed lesion, I didn't see any mucosal features like the granularity that you would see, right? When you lose all the pits with cancer, and they all become a disrupted gland or a sand-like appearance. And then I didn't see, when I water jetted it, I didn't see any friable bleeding or friability. So in those cases, like say, for example, then the next step is I was thinking whether I should, maybe if it comes back as cancer, to send it for ESD. If you take a biopsy from the center, then it becomes very difficult for the guy to resect. But if you take a biopsy from edges, then it is not as difficult because you still have a lot of area that you can cut. And then when you come to that edge, you should be able to remove it. So from the point of, if you're going to send a patient from your place, Sacramento, to some other center a couple of hours away, and taking a biopsy to convince the patient and yourself that you're dealing with cancer is probably not a bad idea, and to take the biopsies from the edge. And if the biopsy from the edge shows adenoma, and you know that this is a depressed lesion, it's most likely cancer, then you are still in pretty good shape to let the patient go in that direction.
Raju had a question regarding the ESD. So would you not want to do an endoscopic ultrasound to look for lymph nodes before you go ahead and do an ESD?
Or an MRI?
Right.
That was my question.
Right. So, you're right. When we say what is the next step, I think we should discuss this to make sure that the lesion can be resected by ESD by documenting that there is no lymph nodes, no extramural spread, and the lesion is not getting into the muscle, right? We have to document those things, especially at least in the rectum with a depressed lesion like this, to consider endoscopic submucosal dissection. So you're right. I think we're jumping the gun and saying that ESD, but it should be the next step of management.
Yeah, but there were a lot of clues with this patient. I mean, he's young. His wife brought him in there. Something is going on. I mean, it should have been the clues that there's something. You need to talk to him. He may be pushing popsicle sticks up there, or God knows what.
Oh, God.
We all said, well, he's got a great uncle who once had cancer or something. But when you see strange things occur in strange people, and so you just the problem is it's hard to get to know somebody, and it is the few minutes that you have, but it's impossible when the wife or girlfriend's in there.
Right. And this is a very sensitive conversation. So actually, it's once we had this diagnosis, I wanted to bring him back to the clinic, and then sat down and talked with him. And then he came out and said he had problems with bowel movements as a child, which required enema suppositories until he was in elementary school. And he was later in the habit of taking senna, milk of magnesia, to move his bowels, and does complain of a lot of straining. So it's, it would have made my job a little bit easier if I had this history up front, because I would be thinking, hey, is this guy at risk for solitary rectal ulcer, rectal mucosal prolapse?
So what did you tell him?
So I told him that, first of all, I told him that his lesion is not cancer, because that was a big sigh of relief to my colleague, first of all. And then I suggested to him that we need to figure out to help with his constipation, basically in terms of fiber, water intake, and use laxatives and avoid any form of digital instrumentation. He didn't have
So you told
symptoms.
him he had a Miralax deficiency or what?
Yeah. So,
Actually, Raju, these people have a high likelihood of having pelvic floor dysfunction. You need an anorectal manometry and a biofeedback. Yeah.
Right. And then the thing is, you always have to keep in mind about pelvic floor dysfunction and giving biofeedback to help them. And what we did was we talked about it. First of all, he was relieved, and then we said, if you still have issues, you come and then we'll take it to the next level in terms of biofeedback. And given his family history and adenoma higher up, I suggested we should do a colonoscopy in 3 years. That's where it ended. He was happy, and his wife was happy. So that's where it ended. We didn't go to the next level of doing anorectal manometry or difficography or any of those tests, because he understood that he didn't have anything serious to worry about, and his wife was very happy, first of all, and he felt that he would manage his bowels by increasing the fiber, water intake, and trying to avoid straining. So
Raju, just a question, if possible. There are some anecdotal reports of malignant transformation of solitary ulcers. What do you think about?
I was actually, when I picked up this case, I actually was trying to look for literature. To be honest with you, I didn't come across, maybe I didn't look hard enough. So I will check it out and see. I think it's a good question. And for the sicker fellows, I felt that this article may be of interest to them. It's a very nice article with a video interview with the author. This is from maybe Sylvia. I don't know whether Sylvia knows this. Rectal.
Free University Amsterdam, in
Right.
Amsterdam. Free
Right.
University.
She's in Amsterdam. She wrote a nice article. And the summary is, as we know, it's a benign condition due to straining, but diagnosis by biopsy, and they have characteristic histopathology. They have images in this article. And one thing is, to educate them about defecation, fiber, laxatives, and pelvic floor physiotherapy. And one thing we should not do is push them to surgery. And that is something important to keep in mind. And any other, for those who want to get a CME, you can text it if you set up the account. And why don't I just open it up for any discussion? And I want to thank Dr. Graham for his input. It really means a lot to hear from somebody with a lot of experience. Sylvia, you want to summarize so that I could put it out there as teaching points? I think it would be nice to do that.
From this case, at least for me, are that taking a good medical history prior to endoscopy is very important. This could have helped us in our differential diagnosis. And another important take-home message for me is that macroscopic appearance is important, but think also to rare conditions. So we were thinking about an adenomatous lesion or invasive cancer, but we forgot that given the location close to anus and because we didn't know the complete medical history of the patient, we had a different suspicion. We had a different diagnosis.
Yeah. All right. Just thank you, Sylvia. Thank you. This is a beautiful summary. Joseph, you want to comment on what you said about on the chat? Oh, you know, Mike. Okay, sorry about that. Okay, Joseph makes this interesting comment you probably have read. Data is cheap, isn't that right? So document with a lot of pictures. I agree. You know, if you look at the radiologists, how many images do they take? I don't know why, as endoscopists, we cannot go to video documentation, but at least we could do photo documentation with a lot of images. All right, any other comments, last comments, Dr. Graham? Shelby?
Beautiful case, Roger. Thank you so much. I think it really makes us sharp and have to keep in mind the differential diagnosis. Not everything that quacks is a duck. And so I think this was a really beautiful case. I hope we can do more in this format.
Yeah.
Let me
tell you one thing. It's very hard to get googlies every time, you know. I don't know how much you know about cricket. Googly is you may want to check it out in Google to find out about a googly. Suresh.
Yeah. Oh, thoughts? Well, I think in women, it's far more likely to think about it because of the fact that our pregnancy and perineal tears, all these lead to a weakening of the pelvic floor, and they tend to have more of these issues. I would have not suspected this in a young man, but there is this other syndrome, or it's not a syndrome necessarily, but this history of some parents being very quote unquote anal about their baby's stool patterns. And I have seen patients who's told me that their mothers gave them enemas to have them go to the bathroom. And so they have had this issue of rectal evacuation since childhood. And what is remarkable about this story is that despite 30, 40 years of constipation, with pelvic floor retraining, they do remarkably well. It's hard to think that this man of 30 who has done this for 30 years is just going to change his whole habit by telling him to take laxatives. That's why I'm thinking that he needs to be trained. So what they have done is they have not learned, they unlearned how to evacuate. And so that entire pelvic floor machinery is not working right. So they have to be taught what they are doing wrong and what has to be done right. So that is as serious a problem, not as serious a problem, but it's also a serious problem that needs serious consideration in intervention. But I would not have. But one interesting thing of when you were describing is what I call cognitive dissonance. So when you are seeing something that you think is something, but something about it tells you it's not, then that's cognitive dissonance. And most of the time we make mistakes when we ignore cognitive dissonance.
Right.
But you were right when you were thinking, why is this not bleeding enough and why is this and that? So that cognitive dissonance, if you don't ignore it and keep it in mind and try and see if we can explain that better, you will be in a better position to get right diagnosis in the cases which are mimicking a commoner condition. So anyway, just
Thank you.
philosophizing on that.
Thank you. Sriram.
I can't agree more than what Dr. Chari said, but 2 points that I still would think that approach would not have been any different for the next case we see something that looks similar or presents similar. And second is that your point about biopsying along the margin to show that it is an adenoma makes sense even if we are considering referral. And third point is that since it is distal in the rectum, even if you biopsy at the quote unquote wrong places, transanal endoscopy and transanal mucosal resection or a TEMS procedure is still possible. So nothing is lost. So because the cancer being so important to diagnose. The next point is that for the reasons mentioned by Dr. Chari, it's important that I would see him again in 3 months and do a flex again 3 to 6 months. If not to convince myself that it is what it is also bring some sort of a discipline and emphasize the need for vigilance in him to that he needs to take this much more seriously and not just be relieved that it is not cancer.
Okay, that's good. All right. All right, I want to thank everybody. Let me just check if there are a couple of okay, it looks like Selvi looked at the Google. So googly is right. It's a ball. Googly is a term that people use in cricket bowling. So it's a ball bowled with a deceptive action. You know, you think that you're going to spin left, but it actually spins right. So that is a googly. So anyhow, thank you so much. I really appreciate it. And this is a very interesting case, but we've learned a lot. Thank you.
Thanks a lot.
Thanks, Raju. Thanks, everyone.
Thank you. Appreciate it.
Bye-bye.